So we've talked a lot about the role of TKIs in advanced stage setting. And these drugs are following the natural progression that most drugs follow in oncology, is that they start late stage and then they move to earlier stage. Not talking about phases, but stages of disease. So we're learning more and more about the role of the curative potential of EGFR TKIs in resected EGFR mutant lung cancer. And we've got ongoing trials, but Jonathan, you want to talk to us a little bit about what we know so far about adjuvant TKIs? These are looking at these trials are looking at after either with chemotherapy or after chemotherapy in resected EGFR mutant lung cancer patients.
So there's been several trials in EGFR mutant lung cancer going back over past several years, looking at adjuvant EGFR TKI for earlier stage non-small cell lung cancer. None of them as of yet have clearly shown an overall survival benefit. One several years ago that was more in an unselected population even showed a potential towards harm. But we've really, with these newer generation drugs and also with the first and second generation EGFR TKIs, we've really wanted to ask in the EGFR mutant non-small cell lung cancer population, can we get the benefit that we see in metastatic setting, and can we bring that forward in the earlier setting? Most recently, there's been a study that was presented at ASCO last year and recently published that looked at gefitinib versus cisplatin vinorelbine in stage 2 and 3A non-small cell lung cancer. It was mainly conducted in China. It was an open-label phase 3 study, and it randomized patients to receive either cisplatin vinorelbine or the first-generation EGFR TKI gefitinib. And it did show that there was a disease-free survival benefit, 28.7 months median disease-free survival versus 18 months. So that was intriguing and promising. We're studying it here in the U.S. in the Alchemist trial, where as part of that NCI-sponsored trial, patients with EGFR exon 19 or L858R are randomized to observation after standard of care treatment. So for stage 2 and 3, they would receive adjuvant cisplatin-based chemotherapy, then followed by either erlotinib or observation. And I think that's going to be a critical study to see if there really is a survival benefit, because a lot of these other studies, once you stop 2 years or so of an EGFR drug, the curves look great for disease-free survival, and then it really starts coming down once the drug is stopped. So are you really improving survival, or just moving the goalposts a little bit and suppressing things until you take them off? And I think that'll be something we'll need to see. I think now that osimertinib is approved for metastatic setting, bringing that into the adjuvant setting, into earlier stage, will be critical, because that if that shows the same benefit as it did in metastatic and better than first and second gen in earlier stage, that could really be something promising for patients in the future.
Anyone comfortable using, so this is a call for clinical trial enrollment. We need these answers. I think there is an adjuvant osimertinib trial going on right now. We of course have the Alchemist data trial that we continue to try to put patients on. Anyone comfortable using adjuvant TKI off a clinical trial? Is there ever a scenario where maybe the patient's enthusiasm overflows and drives the clinical decision making? Does anyone ever have an issue with that, where a patient wants that targeted therapy because they've been told that they have a target? How can you not give me a targeted therapy?
That's a great question. I do not, and I adamantly do not, because we don't have yet the trial data to support that as standard of care. That's why we're doing these clinical trials. So, and as mentioned, although it was more of an unselected population, a study that came out several years ago showed that that there was even a potential towards harm. I think for that, I offer the clinical trial, and I'm very adamant about not doing it off-label.
I think for the highly motivated patients, they can be referred for a trial, but I agree, outside of a clinical trial, these drugs can rarely have serious side effects, and I think we need more data before I would feel comfortable prescribing them.
Okay.